So hi everybody. I assume that no one of you is a radiologist, right? Because you feel comfortable sitting very far away from the screen and you enjoy the sunlight. So I hope that you can appreciate the slides enough because they're made for dark environments and people sitting a bit closer. Anyhow, I don't know if we should have done this first lecture before Eva's lecture because I'm really getting here into the basics of the basics of the basics. And first of all, I would like to thank my colleague Esther Sanchez-Aliaga for some of the pictures. And then we get really into the start of things. So in fact, I thought about it, like if you have never done any medicine, maybe it's good to start with something easy. And I would love to talk to you about the anatomy of the brain and the spinal cord, if this is not so familiar to you, because maybe you're an electrical engineer or something. And later on in this short introduction, we talk about useful MRI sequences and protocols.
Recording stopped.
Oh dear. I didn't do anything in MS and related diseases. So the anatomy of the brain. I assume you're familiar with the lobes of the brain because those are the classic descriptors to describe where you are in the brain. We have like the frontal lobe, the temporal lobe, parietal lobe, brainstem, cerebellum. There's also another way to describe location in the brain, and that is supra versus infratentorial. And what we mean by that, so the infratentorial part is the part in the orange box, and that is the part that is under the tentorium. The tentorium is a part of the dura mater, so the hard skins of the brain, of the meninges, and it separates the cerebellum from the supratentorial part, which is the newer part. So the big part of the brain is the new part with the neocortex, and it's supratentorial, and what is infratentorial is the old part of the brain, the brainstem and the cerebellum. This is what it would look like on MRI. And this is something you will see quite a bit. So basically, supratentorial part
Recording in progress.
And tentorium, infratentorial part. And where does the brain stop? It stops at the foramen magnum. So you have like the brainstem going down, and then the brain goes through a little hole, and that is called the foramen magnum, the big hole. And this is where the spinal cord starts. So everything below is the spinal cord. Regarding interpretation of images, so what you're looking at, you have like different, in MRI, you have different visualization issues. So if you scan the patient like this, then you get such a view, and it's called a sagittal view. And if you scan the patient like this, from head to toe, this is your axial view. And if you scan it like this is the coronal view, and this is how we describe lesions that we see. Those are all also pictures of MS patients. And don't forget the appendix of the brain. So in fact, our brain has like a little elongation, and that is our eye. Not everything of our eye is part of our brain, so I'm not touching my brain right now, but the retina, where the light hits the eye, on the inside of the eye, this is actually a part of the brain. So the optic nerve is also a part of the brain. This is important in the context of MS. Then when we look at the ultrastructure that we can also see in MRI, we have to differentiate the cortex, which is the upper gray matter part, which is roughly 5 millimeters thick, from the white matter that lies beneath it. So this is also essential. Borders of gray matter and white matter, very often abbreviated in science GM and WM. Then we also have to look at the relations to the ventricles. So what are the ventricles? The ventricles are the chambers, here partially on the image, where the brain water gets produced and circulates towards the CSF spaces, so the cerebral spinal fluid spaces of the spinal cord. And finally, for the optic nerve, you have to look at where a lesion, for example, in MS is. Is it close to the bulb, so it's retrobulbar, Or is it more close to the chiasma? Then it's perichiasmatic. And then, in fact, here the nerve goes through the skull, then it's intracanalicular. And the optic nerve itself is covered by nerve sheath. Those are also part of the dura mater. And those can get inflamed too in MS-related conditions. So you have to ask yourself, am I looking at an inflammation of the optic nerve itself? Or am I looking at an inflammation of the sheath, or both? Anatomy of the spinal cord. So we have an MS patient here, and I took, again, a sagittal view. And we have our foramen magnum here. This is where it all starts. And we describe, so this here is called the spine in itself, and it's a bony part. The spine has a canal in its sides, which is the spinal canal. Inside the spinal canal, you have the dura, again, which is like the skins of the brain that just get through. Yeah? And inside that, and all this dura part forms a sac, yeah, like a bag. And inside this called thecal sac, you have the spinal cord. And where does the spinal cord swim? It swims in the CSF. Yeah? So this is how it all communicates. The CSF gets produced in the brain, in the ventricles, and gets like pumped down or floats down the spinal canal. We sometimes call the spinal cord also myelin in medicine, which when you have a myelitis, you have an inflammation of the spinal cord. We do a segmentation of the spinal cord also into cervical spine, which is like related to the 7 cervical vertebrae that you can see here. Then below that you have the thoracic spine and the lumbar spine. But what you have to know is that the spinal cord already stops at roughly the first or second lumbar vertebra, and below that you have something called the nerve roots, the cauda equina, the horse tail. So the cord itself stops already there, and in fact for MS you mainly look at cervical and thoracic spine, and of course something called the cone. The cone is the last bit where the spinal cord is a bit thickened, and that has also some relevance because, for example, you can have a cone and cauda syndrome, which has like certain implications for your bladder function, your erectile function, etc. This is what it looks like more in an anatomical view. Same distribution. And then at the very bottom, the cauda that you can only partially see here. Are there any questions till now? Any anatomic questions for the brain or the spinal cord?
Maybe one. So,
sure.
The lesions, do they usually appear throughout the spinal cord or only on the cervical or thoracic part? Or?
You will find out later.
Okay.
So, to study the anatomy of the spinal cord, what you just learned for the brain is that in the brain you have the gray matter on the outside and the white matter on the inside. But in the spinal cord, this is a bit different. And now you have to imagine that your patient, like on this CT scan, is lying on his chest. Yeah? So not on the back, but on the chest. Which means that the back is on the upper side. And then you get this view of the spinal cord. And you have, do you have a pointer here? Right, okay. So, and then you would have like ventral horns and dorsal horns on the inside, and this is the gray matter. So in the spinal cord, we have the gray matter on the inside of the spinal cord and the white matter on the outside. Right, so we have a switch of gray matter and white matter happening on brainstem level. And what you have to know is that topographically, each part of the spinal cord does something different. So, for example, you have, when you still look at this, this view here, you have like ventral roots that have mainly motor functions and dorsal roots that have mainly sensory functions. And depending on where your lesion is, you have very different effects on malfunctions, because obviously when you have something that is close to the dorsal root, you might more have a sensory problem, that people feel, for example, weird feelings on their chest level. While when you have something that is more in the ventral root and the ventral parts of the spinal cord, you may have more spastic gait, for example. What you also have to know is that the information is usually not processed on the spinal level of the root entry. So we have like nerves coming from the leg going up to the spinal cord, and then they get shifted to then this neuron has a connection to another neuron that goes up to the brain, sometimes several connections, and those connections are sometimes not at the level where it enters. So you can have sometimes the effect that you, for example, have like sensory level issues that manifest at a different level compared to the spinal cord. So that makes it a bit complicated, but this is more something that is the problem of the neurologist indeed. What you need to know also is that nerve tracts, so the white matter with the transporting neurons, transporting the information up and down, are topically organized. This is something I already insinuated. So we have all of those red and blue areas that you see here transport different kinds of information up or down. And this is, of course, relevant for the lesions. And yeah, as I said, nerve tracts usually switch neurons at some point. Right, regarding the anatomy. So what we have a problem because obviously here you see oligodendrocytes and other nerves, cells that get affected by inflammation in, for example, multiple sclerosis. So this is something that happens on micrometer and level, really, but MRI only can reveal lesions that are on millimeter and centimeter level. Which is a big transition. Also, so you see, you can't see the inflammation directly. It only happens on a larger scale that you can visualize it. So sometimes when we say we don't see anything, that doesn't mean that it's not there. And especially in MRI scans where you use like 5 millimeter slice thickness, for example, you can just miss a lesion or the inflammation happens on a level that is too small to be seen. Regarding MRI questions to find MS lesions, there are, of course, international guidelines that advise us on which MRI sequences to use for MS and related diseases. And for example, this is the publications in Lancet Neurology that is still up to date from 2021 that give us very detailed guidelines on what MRI sequences to use in radiology. Who of you is not familiar at all with MRI? Is there anyone who says, MRI, that is actually not my thing? I don't know why I'm in this course. No, okay, this is great. So I assume you're all experts. Okay, so this is what it looks this is what it looks to me as a clinician, basically. The position paper gives very detailed overviews, not only which sequences are out there, but which of them are optional versus mandatory to diagnose MS in the initial setting of making the diagnosis versus also the follow-up. And it also gives advice on, for example, contrast administration, because as you know, we have to choose as radiologist or technologist, do we inject contrast agent or not? So let's go through the MRI sequences. So the classic, if I have to choose, if people tell me your insurance will only cover one MRI sequence, which one do you want? Yeah, then I would always say T2 FLAIR. So T2 FLAIR is like really our bread and butter, and the key sequence for brain MRI, because you can also like use it for optic nerve changes. If you, for example, have a 3D sequence, which is 1 millimeter, you can reformat it, and it very nicely shows you the lesions. It shows you edema, it shows you lesion remnants. Sometimes I have the impression that it also shows me a different signal if some lesion is very acute compared to a chronic lesion, though this is less reliable. The MS lesions appear hyperintense to normal white matter, as you can see here, like those bright blobs there, all the MS lesions, or in fact, as we will see later in the mimics lecture, could also be any kind of other white matter lesion. Additionally, a lot of people choose for normal T2 turbospan echo, usually axial images of the brain, and historically, in my opinion, also proton-weighted images. And in both, obviously, the lesions are hyperintense compared to the white matter. What I find with additional T2-weighted lesions is that small lesions are more easily missed because the T2 flare makes them more prominent. But you can differentiate, for example, if you see a lesion and you're not sure if it's close to the cortex or still in the peripheral white matter, you can see proximities better because it delineates with more accuracy. And then it can tell you lesion borders a bit better. So, but those are only 5 millimeter thickness, and very often in a radiological report, you will hear maybe the lesion is new, but maybe we just missed it last time. Yeah, this is quite obviously when you have a 5 millimeter slice thickness, a smaller lesion can just be between slices, especially if you have a gap. Diffusion-weighted images that might come as a surprise are also quite frequently acquired, not only because a DWI sequence is quickly acquired, usually takes seconds to a minute, and it helps you to identify cytotoxic edema. And cytotoxic edema is associated with acute inflammation, and it helps you to discriminate, for example, active lesions from non-active lesions and also lesion borders, and it shows you, in fact, where the inflammation is happening, so where the immune cells really are and causing trouble. However, I must say that in 95% of cases, I would say that in normal MS, I don't see any diffusion-restricted lesions. So very often this is more for more extreme cases. Yeah, it is also very relevant when you examine like tumor-like MS, but I will show you later in a different lecture. I hope that you're familiar with DWI. Yeah?
Why does it reveal cytotoxic edema? Is it,
versus vasogenic edema? Because only the cytotoxic edema shows you diffusion restriction, whereas the vasogenic edema, in theory at least, does not show diffusion restriction but facilitated diffusion, which both coexist in MS.
And this is again then for acute.
Yeah. So because the theory is that the small bunch of immune cells causes cytotoxic edema, not only because there are many small cells causing diffusion restriction on the image, but also because maybe they also challenge the white matter neurons, because there's of course a lot more metabolic activity, and then you have cytotoxic edema from lack of energy locally. Right. There are also extras. For example, SWI, we've already mentioned it a little bit. So SWI, susceptibility-weighted imaging, is not part of the standard imaging protocol. However, as we'll see soon, it might become in special cases under the new guidelines. So in susceptibility-weighted images, we see deoxygenated blood or blood compounds, but also calcification very well. And the thing is that it helps you with two things in MS and OP. The first thing is the depiction of what is called the central vein sign, which you can see here. So very often we see in MS, and this is part of the pathomechanism of the disease, that those immune cells leave the bloodstream via a vein and causing a local inflammation. So this can be used for differential diagnostics, as I'll show later. So this could be a diagnostic sign, one reason for SWI, and the other reason is also chronic inflammation, as I will show you later. And then there's a big question of gadolinium contrast, yes or no. When I started medical studies, I think everyone, every time who had an MS diagnosis got post-contrast scans. I don't know if that was different in the Netherlands. We got trained in different countries, but over time, and I started medical school a while ago, the use of contrast went down continuously until now. I would say it's maybe 10% of scans, just a guesstimate. Yeah, and that is actually quite good because they found in MS patients that this gadolinium contrast causes deposition in the brain, and in fact, you have chronic changes of the T1 and T2 signal in patients who got like dozens of doses over the time, which also makes it more difficult to identify lesions, by the way. But still, in the active situation, it can reveal blood-brain barrier disruption, and this is what you want to see in active inflammation. It can help you a lot. And to correlate if something is really enhancing or not, so showing contrast enhancement and real blood-brain barrier disruption or not, you are advised, at least in tumor diagnostics, to do a T1 Blanco scan. In MS diagnostics, this is not so relevant because you can assume that everything that looks like enhancing and is bright on T1 is in fact just real disruption. So blood is not really an issue as a differential in MS. But what the Blanco T1 helps you with is to identify black holes. And black holes is like a radiological and sometimes clinical complication associated with bad outcome for the MS patient. And this is like a darkening lesion that shows you that a defect is in fact happening in the brain, so that brain tissue is like really getting resorbed rather than restored. MRI sequences to find MS lesions in the spine. Again, here this is more difficult because usually you'll see sagittal view images, T2 weighted and proton weighted or stir weighted. At least one is necessary to diagnose the lesions, but here taste varies and very much depends also on the quality of the sequence itself. So on the left one side, we have a proton-weighted sequence where lesions are more prominent than on the T2-weighted sequence. I don't know if you can really see it from your view and given the light, but sometimes what you do when you're not sure if something is a lesion on T2-weighted images, you take the proton-weighted for correlation. Even better would actually be to take an axial view. But that very often is not done for time reasons. Regarding post-contrast images, it's pretty much the same situation. We usually do not do a Blanco T1 for correlation, we just do the post-contrast. And what it's also good for is to study leptomeningeal enhancement. Leptomeningeal enhancement, so the enhancement of the thin skin on the spinal cord, is not an issue in MS, but it can be an issue in MS-related diseases or to study or to identify mimics of MS. For proton density imaging, and in my opinion, is just as good as. It depends on a little bit what you're used to. What I like is that the lesions are very bright on STEER images, but of course STEER sometimes can have severe artifacts, especially is prone also for motion artifacts, in my opinion. And then we have more extravagant newer imaging, and that is, for example, phase-sensitive inversion recovery, where the lesion appears dark on the image. As can be seen here on the C2 level dorsally. I know some centers that do phase-sensitive inversion recovery imaging, but I must say that it's still not the norm. Whether it's really more sensitive compared to STEER, I'm not quite sure. Some people say so, and some studies indicate this, but this is, again, not standard imaging, and if it was that great, then people probably would use it more. A typical protocol. This is what a typical protocol at our center looks like. You do a 3D flare of the brain, 1 millimeter, maybe takes you 5 minutes, and then an axial T2 maybe also takes you 5 minutes, a bit more sometimes. And in some cases you do T1 post-contrast, maybe do 1 minute DWI, I didn't add it here. And then the spine imaging, of course, eats up your time because like the T2 weighted sagittal images of the whole spine, even if you leave out the cauda equina, just takes time. And then you need a confirmation sequence like steer or proton weighted imaging. So you end up with roughly 30 minutes scan time if the patient is well. If the patient has a lot of spasticity, or is otherwise not feeling well in the scanner, and advanced MS patients are often such patients, then it can take you substantially longer. You always have to choose also in terms of treatment cost and what you want to treat and what you want to see. Of course, if you have a very nice sequence and you put someone in a 7 Tesla scanner, then you see a lot more lesions. Yeah? And versus you can also, as shown here in this publication, do a very short 2-minute protocol, it was 1 minute for the brain, I think 1 minute for the spine. So you can, it's always the balance between how much do we want to see, how much time do we have, what are the clinical constraints for the patients. As always, the protocol length is going down. So if you want to introduce a new sequence for an MS protocol, it must be a lot superior to what we're clinically doing right now. Otherwise, it will not stand a chance, because what I experienced over the years is reduction. We first did 2 orientations spine, now we only do 1. We first did standard post-contrast, now we usually don't do it. And so this is a very classic issue.
Vera?
Yeah.
I have a question. So the spine imaging, when you see lesions on the spine, does it affect the treatment options?
The treatment options?
Right.
Yeah, this is actually something for Eva. Of course, it adds up also to the information we have on the brain.
Yeah, so the discussion is that as neurologists, we would really like to have standard follow-up of spine scans.
Usually you don't get it.
Yeah, but we don't get it. So, and that is also related to the comment, if you have people experiencing symptoms, we do standard monitoring of the brain, and then we say that there is no added value of doing spinal cord MRI, because if there were any lesions, then it would lead to symptoms, because it's such a, well, small area, you don't have much room for asymptomatic lesions. But I think there are, and there is a number of 30%. I'm not sure that is the case, but the statement that spinal cord lesions can never be asymptomatic is not true in all cases.
Yeah.
So, yeah, I think it's a very long answer for that it could cause treatment or could alter treatment decisions, but we don't do it on a regular basis.
Yeah, and spine lesions are, in my opinion, heavily underdiagnosed. I think we miss a lot of them because spinal imaging is very often insufficient, in my opinion. You just do some sagittal images and they're very low quality. You see the spine on 3-4 slices. If you do this, you'd see them. Yeah.
Yeah, so it's also difficult. So even if you were to do spinal cord scans at every time point, well, I think it would also give some false certainty that nothing is going on, because you could miss disease activity easily.
Yeah. So in summary, for anatomy, bear in mind that gray matter and white matter change inside out. Yeah. So in the brain, the gray matter is outside, and in the spine, it's on the inside. Yeah. The spinal cord stops at L1, which is quite up here, yeah? So if you try to stab someone in the spinal cord or something, you're an assassin, yeah? Bear in mind you have to stab quite high up, yeah? Sorry, just joking. And regarding MRI, so T2 weighted sequences and post-contrast sequences are the essence, and all the other stuff is added. Thank you very much for this first part.